I'm very excited to introduce Dr. Gillian Hanley. Dr. Gillian Hanley is an associate professor in the Department of Obstetrics and Gynecology at the University of British Columbia. Dr. Hanley is a Tier 2 Canada Research Chair in Population-Based Genetic, Gynecologic and Perinatal Outcomes, and the Michael Smith Foundation Scholar. Her research focus combines her substantive interest in women's health with her training in economics, health services research, and epidemiology to answer questions related to gynecologic cancer, primarily ovarian cancer prevention and survivorship. Her research on ovarian cancer prevention has been cited in national and international clinical practice guidelines. I'm also excited to introduce Dr. Hanley's graduate student, Khaye Rufin. Khaye Rufin is a PhD student at Women's plus Children's Health Program at UBC. In 2015, she completed her master's in public health at the University of Nevada, Las Vegas, where she studied critical areas and the costs associated with lead hazard control with the Healthy Homes Program. Ms. Rufin is now working on her PhD thesis, which examines opportunistic salpingectomy during caesarean section and vaginal hysterectomy, as well as national uptake and cross-provincial safety comparisons of opportunistic salpingectomy. Thank you for joining us today, and I will pass the microphone to you, Dr. Hanley.
A bit about what we know about the safety and the effectiveness of opportunistic salpingectomy. I'm also going to show you why we are still making a case for opportunistic salpingectomy. So I'm going to show some national uptake numbers that are less than stellar. And I think those numbers also are going to help everybody understand why we chose to focus and why Khaye chose to do a chapter of her thesis on the safety of opportunistic salpingectomy during cesarean section. And then I'm going to hand it over to Khaye, and she's going to tell you about the really wonderful work that she has done looking at safety of opportunistic salpingectomy during cesarean section in British Columbia. So as we became aware that the fallopian tube was the tissue of origin for most high-grade serous ovarian cancers, Dr. Diane Miller, who worked as a gynecologic oncologist here and is still a professor emeritus here in BC, had a brilliant idea that we could take advantage of this new awareness to prevent ovarian cancer. And this is prevention among people at general population level risk. There was already good prevention in place for people with mutations that put them at increased risk for ovarian cancer, such as BRCA1 and BRCA2. So we're not talking about that population specifically. We're talking about people who are at general population level risk. And the idea that Dr. Miller had was to remove fallopian tubes at the time of hysterectomy, or instead of ligating them for people who were seeking permanent and irreversible contraception. And this became known as opportunistic salpingectomy. And the opportunistic part of that term is very important because we are not recommending that everybody goes and has a de novo surgery to remove their fallopian tubes. We are really just recommending that if you are already having one of these surgeries, rather than leaving the tubes behind, which is what used to be common practice, now we are recommending that the tubes be removed. And, in the beginning, everybody thought that we were a little bit crazy here in British Columbia making these recommendations. And they also thought that nobody would do it. So they thought it's fine to ask people to do this, but you're not going to be able to study it because people aren't going to just rush out and change practice. And they were very wrong. So you can see here that in 2008, which is the purple bar, very few people were having their fallopian tubes removed during a hysterectomy. About 8% of people having a hysterectomy were getting that. And those were actually really early adopters. So people who already understood that this could be effective or might be effective ovarian cancer prevention were on board already. And only 0.5% for people at sterilization. So this really wasn't happening very often. And then by 2019, which are the lighter blue bars, you can see just the vast majority of these surgeries include fallopian tube removal. So people really got on board fantastically. And because of that, we were also able to study this, in real time using real world data. And what we found is that it doesn't take a lot more time in the OR. So Kay is going to show you, we think these numbers are actually even inflated and have come down. So Kay is going to show you some time numbers for how long this takes during a cesarean section. But we were also able to look at a lot of safety data. And what we can say is that there's really no cause for concern in terms of safety. So people who are having their fallopian tubes removed during their surgery compared to people who aren't having their fallopian tubes removed during their surgery are not at increased risk for any of these complications. We found a slight increase in filling a prescription analgesic following opportunistic salpingectomy in the 2 weeks post-discharge from surgery. But this had completely disappeared by 1 month post-discharge. And Kay is going to show you some numbers on cesarean section that this is NSAID use. So not anything particularly concerning like opioids or really the common pain medications that we want to be really aware of who's using them and for how long. So there was also no evidence of a reduced age of onset of menopause when we went looking for that evidence in the population-based data. So people who had their fallopian tubes removed were not starting HRT more often or sooner, nor were they visiting their physicians for menopause-related concerns more often or sooner. So we had some reassuring information around that because there was some concern that by removing the fallopian tube, you may disrupt blood flow to the ovary, and that may reduce age of onset of menopause. And not just our evidence, but all the evidence that's been generated to date, looking at hormone markers following these surgeries has been relatively reassuring. There's been one study that came out that suggested that some patients were reporting some more menopausal symptoms, but there's been about 6 or 7 that have been quite reassuring. So the big question, of course, is, does this work for ovarian cancer prevention? So are women who've undergone opportunistic salpingectomy less likely to get ovarian cancer? So I'm going to show you a bit from our first analysis and then an updated analysis, which is preliminary results. So this hasn't been published anywhere. And you can see we're looking at a lot of people here. So we're not talking small numbers. So there's 43,975 people who had a control surgery in the updated analysis compared to 36,160 who had opportunistic salpingectomy. And the follow-up for the second analysis just adds 2 additional years of data. From the first analysis, if serous ovarian cancers were arising in the opportunistic salpingectomy group at the exact same age-adjusted rate that we were seeing them in the control groups, we would have expected to see 5.3 serous ovarian cancers in our opportunistic salpingectomy group, and we saw 0. So that was statistically significant, and of course, you can't really get better than 0. We also looked at whether or not this could be driven by other factors. So do these groups differ in important ways that change their risk for serous cancer? And they do, in fact, differ in some ways, but in ways that would actually increase the risk for ovarian cancer in the opportunistic salpingectomy group. So the confounders would point to seeing higher rates of cancer in the opportunistic salpingectomy group, not lower. And then, of course, are there unmeasured reasons? So could it be that the people who get an opportunistic salpingectomy are just healthier, they're more proactive about their health, they're just less likely to get cancer overall? And to try and tease that out, we looked at, we did the exact same analysis in using breast cancers instead of ovarian cancer. And so we would have expected to see 22.1 breast cancers in the opportunistic salpingectomy group, and we observed 23, so it was almost identical. And then we did the same with colorectal cancer. So we would have expected to see 9.4 colorectal cancers in the opportunistic salpingectomy group, and we observed 8. So it suggests that these groups are very similar in terms of both known risk and protective factors for ovarian cancer, which I showed you a couple of slides ago, but also just in their general predisposition for developing cancers. So it gives us a lot more confidence that the statistically significantly lower rate of ovarian cancer, high-grade serous ovarian cancer that we're seeing in our opportunistic salpingectomy group is driven by the opportunistic salpingectomy. And when we update these numbers, we would expect to have seen 5.9 by the end of 2019 in the opportunistic salpingectomy group. And unfortunately, I can no longer say 0 here, and I am not permitted to tell you the exact number due to privacy restrictions from the data stewards. But there was a suggestion that it's not, in fact, failed prevention, but that that the opportunistic salpingectomy came too late. So the presence of stick lesion at the time of the salpingectomy can explain what we saw here. And then for epithelial ovarian cancers, we would have expected to see 9.6 by the end of 2019, and we saw 6. But this, I think, is a really important graph. So we know that the histotype distribution usually looks like what we see here in the control group, which is that it's dominated by serous, high-grade serous cancer, with endometrioid and clear cell being the next most common, and mucinous being slightly less common. And you can see how significantly different that pie chart is in our opportunistic salpingectomy group. So really changing the histotype distribution in people who have had opportunistic salpingectomy. So again, this is all really suggestive of reduction in high-grade serous cancers among those who've had opportunistic salpingectomy for ovarian cancer prevention. And of course, I should also tell you that the numbers in the OS group here are very, very small. So just keep that in mind when you're looking at that pie chart, that, you know, as we follow these data, we do expect that to change. So even if we dramatically reduce the risk of high-grade serous cancer over a long period of time, it may still remain the most common cancer in people who've had an opportunistic salpingectomy because it is just so dominant in terms of all ovarian cancers. But we do think that this pie chart is going to significantly change in people who have had their fallopian tubes removed. So all of that hopefully has convinced you that this is a good idea and something that we want to promote, and to have people given the option to have their fallopian tubes removed if they're having pelvic surgery. So the reason that we really wanted to focus on cesarean section is that the uptake is not really entirely where we would want it to be. So before we did this national study looking at more updated numbers, the best uptake numbers that we had for Canada were quite old. So you can see that paper on the left there with the bar chart is up to 2011. So you can see BC, of course, dominating, which remains true. But you know, those were pretty preliminary numbers. So we wanted to see whether or not this had changed across Canada. There is uptake outside of BC. We know that people are doing this quite a bit in the United States. And by 2018, we had 9 countries with statements that supported OS, but Canada was the first. And this paper really points this out. And not only was Canada the first, but BC was the first place in the world to really do this. So, you know, we've really led the way here. And then these are our findings that were published in CMAJ Open in 2022 there. And unfortunately, the data are a bit old, and we actually just last week received a brand new data pull of the national numbers. So we will be updating this very soon. But you can see that, you know, you don't want the maps to look yellow or orange, right? We want to see more of the darker colors there. And the reason that these are a bit funny, and we'll fix this in the updated paper, is that this includes all hysterectomies. And really what would be ideal would be to show the hysterectomies with ovarian conservation. So you can see even BC's numbers are a bit lower than you might expect there with the 53.2, but that's because that includes people who had hysterectomy with bilateral salpingo-oophorectomy. So if they had both their tubes and ovaries removed, they would not be included as having had an opportunistic salpingectomy, which is accurate, but ideally we don't want them in the denominator. But the point here is that you can see the regional variations. So other countries, other provinces are still lower, but doing some of this, it's definitely a big increase from 2011 to 2016 in terms of the people who have their fallopian tubes removed at the time of hysterectomy. But this was really what was quite disheartening for us. And I think sets the stage really nicely for what Kay is going to tell you about, is that the proportion done at the time of tubal sterilization was still really quite low in many places in 2016. So you can see how yellow this map still looks here with, these numbers are small and maybe not easy to read, but like 5.8% in New Brunswick, 5.6% in PEI, less than 1 in 10 people having a tubal sterilization were being offered a salpingectomy in 2016. So it's just a lot of missed opportunities. And I should also say that the official Canadian recommendation from the OBGYN, the Canadian OBGYN Society, was in 2015. So we had a couple of years after that recommendation included in these data. And we still just see that it's really sticky at the time of tubal sterilization. And Kay's going to tell you a bit more about why we think that might be the case. And so that ends my portion of the talk. I'm going to hand it over to Kay now. I just want to thank all these funders. And then, of course, this is not even a complete list of all the names of all the people who are involved in all this work. So, it's really a team effort. So tons of people helping along the way here. And I will stop sharing. And Kay, if you can try again. There we go.
Okay, you can see my screen and hear me okay?
Yes.
Okay, thank you, Gillian. And good afternoon, everyone, and thanks for the introduction. So as mentioned, I'll be talking about a portion of my thesis project that we worked on and completed. So I'll start off by giving some brief background information. Okay, so female permanent contraception is one of the most effective and common forms of pregnancy prevention. One common method used is the tubal ligation, which is also known as having your tubes tied. And it's when the fallopian tubes are cut or blocked permanently, preventing eggs from traveling from the ovaries to the uterus. And this had been the standard form of tubal sterilization for decades. It can be performed at any time remote from pregnancy. It's also, which is known as an interval procedure, or also at postpartum, which is at time of cesarean delivery or within 24 to 48 hours of vaginal delivery. So our study focused exclusively on cases during the postpartum phase and not any time during an interval procedure. So in the US, there's approximately 700,000 permanent contraception procedures that occur every year. And half of these are postpartum bilateral tubal ligations that occur after 8 to 9% of all deliveries. And more than 100,000 are at time of cesarean delivery. In Canada, there's approximately 25,000 bilateral tubal ligations that occur annually. And this, as Gillian mentioned about opportunistic salpingectomy, this does offer us a large number of opportunities to reduce ovarian cancer risk. A research study has shown that those undergoing bilateral tubal ligations can have 26 to 34% reduction in ovarian cancer risk, whereas those who undergo bilateral salpingectomies can have up to 70% decreased ovarian cancer risk. So there has been some concerns surrounding OS at time of C-section compared to OS during benign hysterectomy. due to the state of a pregnant uterus versus a non-pregnant state, particularly with respect to potential increased risk for bleeding. So there's differences in the vascular anatomy. During pregnancy, there's an increased blood flow to the uterus and fallopian tubes. So during a C-section, this can introduce potential increased risk of vascular injury, increased operative time, and blood loss. Patients also tend to be younger in age, so the onset of reduced age of menopause has been a concern. And adhesive disease also may make surgery more challenging, regardless of the timing of salpingectomy. There can be some limitations in visualization of mobility of pelvic structures. And many of the patients that undergo these procedures have already had a previous C-section done. So the aim of our research study was to determine whether there are any differences in risk for perioperative and postoperative complications following OS for tubal sterilization compared with tubal ligation during a cesarean delivery. And our research question was, is OS for sterilization safe when performed in the same hospital stay as a cesarean delivery or vaginal birth? We hypothesized that adverse outcomes will not differ between those undergoing OS and those undergoing tubal ligation when performed in the same hospital stay as a cesarean delivery or vaginal birth. Our study design involves a large population-based retrospective cohort study, and we included all individuals in BC who underwent the two surgeries, OS or tubal ligation, at time of C-section or after vaginal birth from 2008 to 2021. So for our data sources, we used hospital-based administrative data, such as the discharge abstract database, and it contains data on all hospital stays and day surgeries. These data were linked with data for all physician visits and the BC PharmaNet, which is a database that contains all prescription drugs dispensed in community and outpatient pharmacies. So here's a flow chart of all the patients that we included and excluded from the study. We identified patients who underwent OS or tubal ligation using Canadian Classification of Health Intervention Codes, or CCI codes, and we identified the procedures of interest using ICD-10 codes. There were 19,774 surgical sterilizations during a live birth hospital stay in BC between our study period. And we excluded any study IDs that were not listed in the demographics file or were coded as male, anyone not registered in the MSP in the year of surgery, those who had different procedures, any stillbirths, and those that didn't have 6 complete weeks of follow-up. There ended up being too few surgeries occurring after a vaginal birth, so we decided to focus exclusively on cesarean deliveries. And our study cohort ended up having a total of 18,184 individuals, with approximately 8,400 in the OS group and 9,700 in the tubal ligation group. So for our outcome variables, we examined perioperative complications that included total operating time, the length of hospital stay, surgical complications such as infections, anemia, incision complications, pelvic organ injury, or any return to the OR during the hospital stay, and any hospital readmissions. We also examined complications that would not be captured in hospital data, so we used physician visits data to examine visits to a physician for a post-operative infection, or any physician visits that resulted in ultrasounds or lab visits in the 6 weeks following hospital discharge. We then examined whether people who underwent OS were more likely to fill a prescription for an antibiotic or prescription strength analgesic in the 6 weeks following discharge. And these were identified using anatomical therapeutic classification codes. We didn't have access to any over-the-counter medications. For our statistical analysis, we compared these outcomes between patients who underwent OS for sterilization versus patients who underwent tubal ligation as a comparator surgery using chi-square tests for categoric variables and independent sample t-tests for continuous variables. We ran logistic regression and controlled for any confounding variables such as patient age at surgery, income, previous C-sections, previous gynecologic surgeries, and number of live births. So now I'd like to describe some of the patient characteristics in our cohort. We found that OS patients were slightly older, with a mean age of 34.5 versus 33.6. The largest age category for both groups was 35 to 39, and this represented a higher share of the OS group. There were a slightly higher rate of OS patients who had at least 2 live births, at least 2 previous C-sections, and a significantly higher rate of OS patients who underwent at least 1 previous gynecologic surgery. There were slightly more tubal ligation patients in lower income quintiles. So for our results here, you can see the proportion of OS cases versus tubal ligation in BC during our study period. The light gray shade is tubal ligation and the dark gray is OS. So this figure shows us that OS has significantly increased over the years compared to tubal ligation within BC. So in this table, we have some results from our outcome measures. At first, I wanted to show the mean length of hospital stay. Both groups were analyzed by year, and we show that both groups in our cohort stayed significantly longer in the earlier study years. And OS patients stayed longer compared to tubal ligation patients on average at 3.26 days versus 2.78 days. But then the mean length of stay for both groups decreased over time. And from 2010 to 2021, OS patients had a slightly shorter length of stay than tubal ligation patients. OS patients had longer OR times by only an average of approximately 8 minutes. And we found that there were no other significant differences in any of the perioperative complications we examined, as well as any differences in the postoperative complications, and no difference in the number of physician visits between the 2 groups. So this table includes unadjusted and fully adjusted odds ratios of complication outcomes. The fully adjusted models, as I mentioned, we controlled for variables such as patient age, income, previous C-sections, previous gynecologic surgeries, and parity. And we found no significant differences in perioperative complications between the groups. But for post-operative complications, there were significant differences in medications that were filled. OS patients were significantly less likely to fill an antibiotic with an adjusted odds ratio of 0.83. And they were more likely to fill a prescription for an NSAID with an adjusted odds ratio of 1.15, and less likely to fill a prescription for an opioid with an adjusted odds ratio of 0.89 compared to tubal ligation patients. So our results suggest that patients who underwent OS for sterilization and tubal ligation were largely at statistically similar risk for the perioperative and postoperative outcomes we examined. However, there were significant differences in prescribed medication use. For the OS group, they were at 21% decreased odds to dispense antibiotics, 13% decreased odds of dispensing opioid agonists, and 16% increased odds in dispensing NSAIDs during the 6-week postpartum period. However, these results need to be interpreted with caution, as PharmaNet doesn't capture medications that are purchased over the counter, and most NSAIDs are purchased over the counter. For clinical implications, we believe that OS at the time of cesarean delivery is safe and doesn't increase any risk of perioperative or postoperative complications. While there was a slightly increased risk of filling a prescription analgesic, this was only for NSAIDs and not opioids. And then for future research, we do recommend that studies use patient-reported outcome measures to understand the severity of pain and use of medication after surgery. We also recommend focus on prospective multi-center long-term trials on safety outcomes, including the function of the ovarian reserve, particularly at the time of cesarean delivery. So our study is strengthened by its population-based nature. It's the first study to examine an entire population of OS patients during the same hospital stay as a live birth. The study includes all hospital stays where both a live birth and tubal ligation or bilateral salpingectomy for permanent contraception occurred in BC. So there are no biases resulting from focusing on a single hospital or center, and is also the first to analyze prescription drug use. So previous safety studies in cesarean delivery with OS populations have suffered from limitations, including small sample size, as I've highlighted in this table. And they were mostly single center studies, which reduced their power and generalizability. These studies do have similar safety outcomes that we've measured, and all of them have shown no differences in their safety outcome measures. Our study also has limitations of retrospective and observational design. There is a risk of precision coding inaccuracy in the database. However, these imprecisions are unlikely to be related to OS status, and so they're unlikely to be a source of significant bias. Second, we were limited with our use of the PharmaNet data, and because it didn't include over-the-counter medications, many of the NSAIDs used in this cohort were likely not captured. It makes the significant difference in NSAID use less reliable, as many people in both groups may have filled NSAIDs over the counter. And we also don't actually know if the patients took the medications. Our data simply indicates that they've filled them, and the likelihood of them not taking or completing the medications is high because the medications studied are generally used as needed. So to summarize, we do report no differences in peri and postoperative complications between OS or tubal ligation patients during the same hospital stay as a live birth at time of C-section, except for a slight increase in operative time for OS patients by approximately 8 minutes, which is comparable to previous studies, and a slightly increased risk of filling a prescription for an NSAID during the 6 weeks post-discharge, but this result did not affect the safety outcomes overall in the data. And given the recent preliminary evidence that Gillian shared, showing fewer observed cancers in OS patients, particularly high-grade serous carcinomas, as well as a growing body of evidence around safety, and with equal efficacy for contraception, we do believe that OS at time of cesarean delivery should be offered to patients. It should also be counseled around the around ovarian cancer risk reduction. And so ultimately, we do believe that opportunistic salpingectomy is a feasible option that is effective and a safe ovarian cancer prevention strategy. So thank you for listening, and to everyone that supported this research project.